I wish, I wish you a very nice weekend. Thanks, Dr. Ahmed, for the nice and the kind invitation with my dear colleagues, because today you're having a bunch of friends and very efficient pain physicians. So we'll start with the basic topic, which is safety during pain management intervention. Uh, Pain management intervention should be done with a condition cause no harm. Why should we put that condition? Because we have a replacement. We have something to replace the intervention. So there is no need or there is no point to expose the patient to a harm that is not calculated. Let's first define what is a safe pain practice. It shouldn't be causing any harm or injury, of course, and having a low incidence of adverse reactions or significant side effects if you follow the instructions and the guidelines to do it properly. And finally, it should have a very low potential of harm under conditions of widespread. It means when I teach my colleagues and my colleagues teach another colleague, it should be reproducible without increase of harm. I mean, it shouldn't be based on the talent or the expertise of one person. The technique per se should be by itself having its inert safety. First, I want to remind you of something. What happens if a fault happens during pain management intervention? As you see here, there was in 2012 reports that was repeated or summated in 2016 about fungal meningitis related to contaminated epidural steroid shots. A single fault, a single fault that happened there, there was a contamination of the triamcinolone vials. During this, there was an outbreak of meningitis, encephalitis, and some of those patients had cases like cerebral strokes. It was recorded at that time at 2012, like 700 cases contaminated. Over the time, they were reaching up very high numbers. Some of them are good, some of them were having symptoms through symptoms and signs, and they had then like 64 mortalities. So it was one line of preparation of a drug ended up with this catastrophe. Another very interesting case report from the anesthesia journal in 2012 again. I don't know what is wrong with 2012 that year. There was a patient with an interscalene catheter, a young, healthy adult, did the interscalene catheter during some repair surgery in the upper limb. The catheter was not introduced with any drug, and it was left with the patient. He went to the ward. Everything was perfectly okay. Late in the evening, he started complaining of pain, so the anesthesiologist went there, gave him a bolus in the interscalene catheter, and then he stayed there for 20 minutes. Everything is perfect, everything is calm and perfect, and he's starting to have some analgesia. The doctor went to the OR again, and in the morning, they found the patient completely cyanosed and arrested. He was arrested maybe at 12 a.m. Why didn't he call for help? Because he was paralyzed. Why didn't he express anything? Because he couldn't move, he couldn't press the button, he couldn't express himself, so he died peacefully. What happened? In the autopsy, they found that the catheter traveled from the interscalene space through the foramen and then epidural. And he was, of course, in the peripheral nerve, we can give around the peripheral nerve a kind of high concentration of local anesthetic. That's why it was like having complete spinal or complete epidural. So the patient stopped breathing and also he died. So it can end up catastrophic. It's very important that safety is a cornerstone in any pain management intervention. Complications of pain management intervention can happen due to several things. It could, first, it's commonly devastating. I mean, the complications of pain management intervention commonly are grand major, devastating to the patient, to the physician, and often avoidable. How does it happen? It could be related to the technique, the same technique, the perfect technique, but it's related directly to the technique. It could be due to the injected drug, whether the dose, the volume, any fault in that, or improper technique, I mean, mistaken place of the needle or the injection site. How to minimize technique related complications? First, image guidance. Image guidance made a huge change in our practice in pain management because, of course, we're mostly familiar with the fluoroscopy guided techniques. It increases precision, it increases the safety, increases the comfort for the patient because you don't keep trying to find your place. You can find your place immediately under vision. It gives a better outcome, better science, and new procedures were created. What about the ultrasound? Of course, we have people who are experts in ultrasound guided regional techniques. When the ultrasound era came, it gave us a different kind of precision. We can see the needle, but it's the gold standard for the vessels. I mean, whenever you have a problem or a risk in a technique, and it's mostly related to the vessels, the gold standard, or maybe the higher safety level will be achieved by the ultrasound. What about the drugs? Of course, we're familiar with that topic, local anesthesia toxicity. You don't need me to remind you that lidocaine, we have a limited safety margin. The maximum single dose of infiltration that can be given to a patient is 30 cc of 1%. And if you're doing still regional anesthesia, you know that you can achieve this volume very fast in so many techniques, especially when they are done bilaterally. For bupivacaine, we have a higher level, a wider limit for safety and volume. The toxic plasma level universally agreed on lidocaine 5 microgram per ml and bupivacaine 1.5 microgram. The cardiac toxicity, of course, greater or elicited more with the bupivacaine, but the CNS toxicity is noticed more with the lidocaine. What about the steroids? Can be the steroids by themselves toxic? First, side effects from steroids during spinal injections are not uncommon. As regards the toxicity of the drug itself, it's not very much known. But I want to remind you something, especially our colleagues from Egypt. But sometimes it's not related to the drug, it's related to the preservative material. And I'd love to take the opportunity to warn you about one of the formula that we have currently in Egypt of triamcinolone acetate that is carrying the preservative material, which is ethyl alcohol. It's very small dose, but it can be neurotoxic. So any mistake can happen. You have to check every time what is the drug inside, and not only the drug, but the preservative material. But there is no strong evidence about the steroids by being neurotoxic by themselves. However, still any neurotoxicity can happen, or especially if it is inadvertently were injected not in the epidural, but in the CSF. But we have reports of systemic effects of glucocorticoids, of course. You'll have the same side effects like hypertension, hyperglycemia, a headache, insomnia, flushing, nausea, vomiting, whatever. And by the way, it doesn't take a huge dose in some patients. I can recall one of my big patients in size. She was over 100 kilograms, and she had just bilateral sacroiliac. And to my surprise, they called us in the morning, and she was having all the symptoms of having pulmonary congestion and dyspnea and so on. So it can happen sometimes in some sensitive patients at a lower dose. However, you have to be cautious with every patient. Patients are when the patient is at risk, you need to take more safety precautions. Like what? Like the patients with heart failure, hypertensive, diabetics, the obese, the elder. You have to be more cautious in those patients. I'm stating here a dose of 3 milligram per kg per 6 months because it took me some time to dig in the literature, and I found this formula in one of the very old books. This is our dose limit for the triamcinolone or the dipomedrol per kg per 6 months. Why do we mention it in 6 months? Because we have to calculate the numbers of intervention. Sometimes you get the patient for repeated injection. So it's cumulative dose. You need to check the dose and you multiply by the body weight per 6 months. What happens if we have an improper technique? The most famous improper place for injection is the intravascular injection. Of course, you might face local anesthetic toxicity. It can end up by seizure, irritability, cardiac effect, or cerebral effect, even in very small doses intra-arterial, especially in the vertebral vessel. Half a ml of lidocaine can induce seizure. So it's not just related to the volume, it's related to the site of intravascular injection as well. And they can end up by respiratory arrest. I brought this MRI for a reason, because we're going to talk about the barotrauma to nerve or the spinal cord. Injection into a nerve or a spinal cord can cause spinal cord compression. So you need to know where is the needle tip exactly presented, and you need to understand the anatomy. And after that, you need to calculate the risk. If you have a patient with multiple discs, multiple compression, maybe myelopathy in the spinal cord, your eyes should pick that. There is no need to inject epidural here, because you might add to the compression that is already happening. I mean, very small volume in already very narrow space can cause this barotrauma. But there is a chemical trauma that might happen if you inject it directly in the nerve or in the spinal cord. How to avoid? First, know what you are injecting, the proper dye. And this is a big issue, because sometimes you can mistake the dye. Some of our colleagues keep arguing about the ionohexol, and if we can inject anything of the other formula that can be injected intravenous, it's forbidden. We use only the ionohexol because this is the only dye that is used in the myelogram. So it's easy to use and safe to use. Read the labels carefully, and you need to draw up, this is my personal tip, draw up your own medications by yourself, all by yourself, because you're the one who is going to hold the needle, and you're the one to be blamed if anything happens. A real life interventional pain, you need to be prepared, anticipate the problems, and react appropriately to an emergency. I'll give you an example for the setting for a cervical epidural. This is what I do. The laryngoscope, the endotracheal tube, all the emergency drugs are drawn in the syringes. Everything should be prepared. I take only 5 minutes end to end, and this is it. But it's better to be prepared than to start running and calling for help and so. So be prepared, be proactive, anticipate the problems, and react appropriately. What do we call a prepared facility? There should be, for any intervention room, you need a crash cart, a suction, defib, medications, trained personnel, and transport plan in place. I mean, if you're working in a very narrow facility and your patient is prone, if anything happened, it's very difficult to turn him. You should have to plan how are you going to transport the patient if anything bad happens. Okay, when to anticipate the increased risk? As I mentioned before, post-surgical anatomy, the obesity, chronic medical conditions, very bad medical conditions. The elder, of course, are very risky. Head and neck procedures in general, even in very young patients, and the inexperienced injectors. I brought you this image to remind you, for example, if we're going to do a stellate ganglion block here. Can you see how many important structures around your needle? It's very important to know exactly the anatomy and know where is the risk can come from. How to avoid the intravascular injection? The easiest is suction, but it doesn't work all the time because it might be a very small, low pressure vessel. But using the imaging aid is very important. As we mentioned before, the ultrasound, the C-arm is having the digital subtraction technology that I advise you to use it. Digital subtraction, in the digital subtraction technology, we subtract from the image the bones. Look at this. This is the patient. Of course, there is previous fixation. This is lumbar transforaminal, and this is the epidural spread. But it could be crowded, this image, and you might miss something. If you feel like that you're going to miss something, do the digital subtraction. This is an option in any modern C-arm. Just ask the technician to help you with. Look at this. Now the image is empty. We can see exactly the epidural. If anything sounds like a vessel, it will be more obvious this way. So I advise you, when you use the C-arm, use a digital subtraction, especially in the head and neck procedures. Spinal cord injury, how does it go? How does it occur? It can be by direct trauma or the barotrauma, as we mentioned before, but it could be compressed by hematoma or abscess or injection, the injected medications themselves. Chemical trauma, it can happen due to infarction. Until few years ago, there was like four case reports about having paraplegia after lumbar transforaminal epidurals as high as the level L2 or L1. And this is one of them. Of course, it could be due to injection around the arteria radicularis magna that we all know that it can be aberrant, and there is an incidence of having it down to the level of L1, maybe L2. So there were like very few cases accumulating, but 2 years ago we had another very interesting, but actually a bad a case report about a paraplegia after transforaminal epidural injection in a patient due to severe lumbar disc herniation. And by the way, when I revised this case report, I found that the patient was very old, and what happened here was coda equina, which is very strange. However, you have to be cautious because it might happen even at low level, not only L1, L2. I brought you some images of the ordinary epidural spread of the dye, the ionoxol. This is a fluffy central, not so dense and spreading, and you can see here even the foramens and some of the nerve roots. This is the normal and the good epidural spread. And this is from the lateral, it looks like that as well. What about this? If you find something central and dense, and if you inject here half a mil or 1 mil and it's shooting there, you have to suspect intra CSF, that the spread is CSF. And this is how it looks from the lateral. What about this? This is one of my patients, by the way. This patient was having a failed back syndrome, and I've done him caudal epidural, and I have injected the dye just like 1 ml. And initially, the spread of the dye was like okay. Commonly, I check from the lateral. When I started injecting the injectate itself, I found this just after 2 mLs. I kept running after this thin line. To my surprise, it was up to dorsal 6. What is this? Can you guess? This is subdural. And for the subdural, 2 ml can cause very high levels. If you're going to inject a big volume, you can have something like full blockade up to that patient might arrest. So you have to be very careful. If you find some thin line like this, it could be subdural. Of course, this patient was helped in a semi-sitting position. We kept him in the recovery room for 1 hour, and after that, he was okay. When in doubt, pause, obtain further images. C-arm images should be two trajectory, at least AP and lateral. If it's not satisfactory, take the oblique and more oblique and more oblique. You might find something by your eyes that can be alarming. Inject further contrast. Inject a tested dose of lidocaine. Consult a partner. Cancel the procedure and observe the patient, of course. I brought here just a small slide, very small, very minimal slides about the PCA, because to us, to some of our colleagues, it's like an intervention. PCA, of course, you're familiar with. We don't have to run through, but I want to tell you about the JCI safety goals that could be applied to pain management, especially to the PCA. For improving the safety of the PCA performance, especially in the hospital, I advise you just to minimize the number of protocols so as to avoid confusion. You don't have to have all the drugs protocols for every single opioid in the hospital in every single dose. It shouldn't be like that, because this might cause much confusion for the staff that they are helping you, and it can end up badly, by the way. So from the previous slide, this is the most important thing that I'd rather I like to tell you. There is something called the FIMIA. FIMIA is a failure mode and the effect analysis. And this is a term that's used by the quality people. And I kept running through some FIMIA reports from the manufacturing companies of the PCA. And I found one of them in 5,110 cases. There were a good number of cases with complication. They did the analysis, of course, and they found this. Improper dose and quantity was the highest incidence of complication. Unauthorized drug, so it is off label. Omission of errors, prescribing error, wrong administration of the extra dose, wrong drug preparation, wrong time, wrong patient, wrong dose, wrong route. So it's almost our fault. Another one of these FIMIA reports was very interesting as it stated major catastrophic events. And they found that 50% of coming from 131 of major catastrophic events, the operator error was associated with the adverse events. In another FIMIA report, they found that the background infusion was the reason for the major incidents that happened. So if we calculate all of this and collect it together, take care during the preparation, revise and keep revising your protocol, try to restrict the number of protocols to avoid confusion and avoid the background infusion as much as you can because it caused a lot of problems. And finally, pain management intervention is minimally invasive but maximally dangerous. So you have to be very careful while doing it. How can we avoid complication? To conclude my to go home message to you, get the best training available, learn anatomy and safe injection techniques, learn to recognize and avoid the problems, became extremely good in what you do. Don't try to be a maverick. You're not a hero and you'll never be. Just be a safe interventionist, and this is more than enough. Practice within your capabilities, know your limits, gain experiences, and expand gradually. Evaluate the patient and get a careful patient history. It can save your neck. Thank you very much.